Good afternoon.
It's not very easy to talk in the afternoon. Those who did in the morning were lucky than we are. I'm going to share you an experience of some patients we managed with my co-author, Dr. Wawero, who is in the audience. Next slide. Urethrostricture surgery is not without failure, as we have had before in the previous lectures, and urinary diversion is an alternative. Betrothal of catheterized or continent conduit made by way of appendicitis vesicostomy should be considered as an alternative, especially in poor resource centers. Betrothal of principle is discussed with 2 case presentation and literature review. Next slide. Surgical treatment of urethral strictures involves urethral dilatations, DVU, urethral stents, urinary diversion, and urethroplasty. What about when all these fail? Even Sanjay this morning said that he has a success rate of 90%. Even if you do multiple urethroplasty, you cannot be 100%. So urethroplasties are not 100%. Musao and Moteta, in a prospective follow-up of 88 patients, they had a success rate of 92%, though they followed their patients for only 3 months. Dakum et al., in a retrospective study, that 2 patients, again, they had a restrictory rate of 32%. Tijani, 70% success rate. In a paper we did with Dr. Dagwada, which we have not published, we had a complication rate of 35%, which included restrictor and sepsis, in a series we did for Kenyatta National Hospital. Now, urinary diversion can be temporary or permanent by way of cystostomy in urine retention, urethrostomy, betrothal, and ileoconduit. The first case report, Mr. J.N., a 25-year-old male, was involved in a road traffic accident in the year 2011. He sustained urethral injury, which resulted to a urethral stricture. He underwent multiple urethroplasties, including a buccal graft. He developed a fistula, length of a cycle. Colostomy was done, repeat urethroplasty, closure of the colostomy, back to fistula. This patient presented to us in March 2013, that was last year. We did a repeat MCU. And this is what we found, that there was this, that is the bladder, and that is the colon, the rectum. There was this fistula there that was communicated there. But as you see, there was hardly any normal posterior urethra. If you look very closely, this one is a stone. Unfortunately, even the radiologist did not see this stone. So when we went to do the surgery, this was actually a surprise. Next. Same slide, next. Now the patient was prepared for theater for the closure of the fistula and possible urinary diversion, because we thought this was a difficult. He had undergone surgery about 6-7 times. An informed consent was obtained, and we did a bowel prep. The reason you must do a bowel prep is because you may not use the appendix, you may have to use the small bowel. Intraoperatively, we did a check urethroscopy, and that revealed a complete obliteration of the urethra at the membranous level. By perineal approach, the fistula was explored and the rectal side was closed. There was hardly any normal urethral tissue, and therefore a decision for urinary diversion was made. Bladder was opened and a large bladder calculus was found. The bladder was bivalved and the fistula side of the bladder closed. There was no evidence of a viable posterior urethra. A betrothal of continent catheterizable conduit was made using the appendix of a Foley's 14 French catheter. The catheter was removed after 2 weeks. The patient was instructed on how to enter the bladder. Next. This was the stone we found. Next. And this was the patient post-op. You can see there was a lot of scarring because of the previous surgeries. Next. The patient did well post-operatively, and he was taught how to empty the bladder forwardly. Next. Case number 2, Mr. SL, 26-year-old male involved in a road traffic accident. He sustained pelvic fracture, bladder and urethral injury. The bladder injury was managed as a suprapubic catheter inserted. A bulbar urethral stricture was noted. He had multiple staged urethroplasties, including again a mucosal buccal graft. Next. An MCU after the last urethroplasty revealed an extensive scarring of the postmembranous urethra. This was the last MCU ascending ureterogram we did. And you can see there is restricturing all the way. There's actually hardly any normal tissue, and there were also false passages from previous boogylage. Next. After consultation with my co-author, Dr. Wawero, and the patient, we made a decision to do a urinary diversion. We did a mitraphanol, and the patient did well post-operatively. Next. This was the patient. See, that is where the stoma is. The patient has to catheterize himself through there. What you see there is not infection, it's actually mucus from the appendix. Next. Now, the principle. Mitraphanol reported the use of appendix implanted into the bladder as a continent conduit in the 1980. The appendix was first used as a continent catheterizable channel in children in the USA in Philadelphia in 1982, and was named by John and Howard as the mitraphanol principle. Since then, many institutions have reported the use of the principle in the pediatric population. It has become the most widely used alternative continent mechanism in the world. Next. It is used in bladder extrophy, epispadias, and spina bifida. Next. Now, mitraphanol reported the use of the appendix or the ureter. Others have reported ileum, fallopian tube, cecum, and stomach. Others have also used it for achieving a continent stoma for antegrade enemas. Next. The principle describes the creation of a flap valve using a small diameter sample conduit, like the appendix. The small diameter of such facilitates catheterization. As the filling of the reservoir occurs, the channel is compressed, leading to, by hydraulic principle, to a higher resistant flow and the pressure produced in the reservoir. Next. And that is how we harvest the appendix, and then we preserve the mesentery and the blood supply. Next. That is the conduit as implanted. Next. This is the same mechanism employed in ureteral implantation to prevent ureteral reflux, especially in kidney transplantation. A sample conduit may be more effective compressed against a firm reservoir wall in bladder rather than in the intestine. Next. In conclusion, difficult, complicated urethral strictures can be managed by urinary diversion. This improves the quality of life for those patients. Mitraphanol principle may be preferred in this part of the world compared to other diversions like the ileal conduits that use appliances. It is simple and easy to function. Thank you.